Thank you for watching this video on hand grip strength assessment. Therese?
Thank you, Barbara. Welcome to this presentation about hand grip strength examination. I'm your host, Therese Schollard. This is very exciting to be sharing the grip strength exam toolkit with you because the hand grip exam, while needing to be performed exactly as the methodology states, is easy and fun to do. Grip strength complements our nutritional assessment as part of the nutrition-focused physical examination, and when done correctly, provides meaningful clinical information and is therefore connected to both identification of disease-related malnutrition and to some measures of age-related muscle wasting and sarcopenia. This presentation is one part of a multi-part program that is designed such that individuals and small groups can teach one another. You will learn how to perform what is considered the gold standard method of hand grip examination by both the American Society of Hand Therapists and the American Society of Surgery of the Hand. Correct performance of the exam and interpretation of results will assist in assessment of nutritional diagnosis as part of the Academy Aspen Consensus. Here is my disclaimer. The complete grip strength training program consists of a number of steps you can see on page 1 of your toolkit. Each step needs to be completed as part of all the learning. It takes a while, so plan this learning over a few weeks or months. Your employer may have additional competency requirements, though. So it's important to let you know that I have no financial relationship with the equipment manufacturer, the American Society of Hand Therapists, or any other group, and have received no financial support for this education program. The program is donated from 5 years of work by myself and generous support by others to help forward improved identification of disease-related malnutrition by use of the consensus. I hope you find it as interesting, engaging, and as fun a topic as I have, and that you can expand your own clinical skill set and your depth of understanding of how undernutrition impacts muscle function. I hope you will gain confidence, depth, and value in your nutritional assessment and use your new skills to help to increase identification and thereby work on interventions and to, in the bigger picture, support changes in our healthcare systems to prevent and reduce incidence of protein-calorie malnutrition. You can read the course objectives on page 3 of the toolkit. So I'd like to share the backstory, as I recall it, about how grip strength became one of the 6 clinical characteristics to help determine protein-calorie malnutrition in our patients. What I recall, it was an honor to be part of the Academy Aspen Malnutrition Work Group in 2010. We started working on the consensus characteristics for malnutrition that were then eventually published in May of 2012. Our group met often, and at one conference call, my memory is that our chair, Jane White, said that she talked to Gordon Jensen, our physician advisor, and he suggested we look at functional status as one of the potential clinical characteristics, and that hand grip strength had much nutrition-specific literature supporting its use compared to some other functional measures. So we went on to review the functional measures. I'd known and read about grip strength over the years, but had never really spent much time or energy thinking about it, other than understanding that if someone was malnourished, their muscles would not perform as well as if they were healthy. The work group reviewed literature on functional measures and nutrition, including grip strength, and achieved consensus that grip strength would be one of the characteristics representing patient functional ability. There was indeed much historical literature on its use and relationship to nutrition status. Grip strength has been used as a practical exam at the bedside for undernutrition, as it is relatively inexpensive and not difficult for the patient or the examiner. You can find this background information in the reference list in the consensus. The articles are listed in the toolkit reading list. At the end of one particular conference call, I remember saying something to the effect that I was really intrigued by this topic and would be happy to work on that characteristic further at some point. And the group was okay with this, as there was so much work to be done at the time, and it was not on the top of the needs at that point. I remember thinking to myself that I would come up with an easy handout about how to perform and interpret the examination for dietitians. How tough could it be? This webinar and the toolkit are what my easy fix idea turned out to be after 5 years of study, practice, and effort. Please see the toolkit for the names of the many special people who have helped this project along, let me train and practice with and on them, and did not dismiss my interest as unuseful or dismiss grip strength as unmeaningful. This training program has a number of parts that must be completed to assure that you can perform the examination and interpret and document the results. Please read the methodology article in your DPG newsletter and read the reading list. Become familiar with the forms and the materials in the toolkit. I recommend reading before viewing this webinar. You will need all of these materials, the understanding from reading, and the webinar to learn what you need to know. This reading and study is really important to understand what you're doing and what you're going to be doing and why you're doing it. Performing the actual exam itself is only one part of the learning that you need in order to include grip strength in your skill set to assess and interpret it in its application. There is intentional redundancy in the program and this webinar as I repeat information and go over segments again purposely. And we're learning on a webinar rather than a person, so I wanted to make sure everybody gets the information. You may need to watch the webinar more than once and go back over parts of it. By the end, you will be able to put the parts together. And it's okay to watch the webinar and then read the articles. Again, I think it will be easier to learn if you read before the webinar. However, as long as you do all the parts, you will gain your new skill and the ability to apply it. Ultimately, I want everyone to know how important the methodology is and to not be casual with it. So let's get going with some refresher about muscle. So we as dietitians get it that muscle strength will be impaired in malnutrition. We know that muscle strength correlates with whole body protein status, body cell mass, and the BMI. When a person or animal, for that matter, loses muscle mass, this leads to decreased muscle strength. The consequence is loss of physical function. That represents difficulties recovering from surgery or illness and inability to take care of oneself. So the idea of measuring muscle strength is logical and one way to determine the condition of the muscle. People have looked at this relationship between grip strength and a number of outcome measures that have a relationship to impaired muscle function. And you can see some there, hospital stay and outcomes of daily living. And it's also been found that grip strength is a superior predictor of functional ability in healthy and sick, especially the elderly. And like so many results in nutrition and metabolism, that the pattern of results in an individual is really meaningful. So there are also many variables potentially affected by changes in grip strength. And this is a summary excerpted from a very nice article by Mary Russell in 2015 from Nutrition in Clinical Practice. And you can see the various conditions such as a nutrition status of patients with diabetes and inflammatory bowel disease, things like that. So I was surprised actually to learn that muscle dysfunction is not entirely understood. One of the big new learnings for me was that it is not just the muscle mass that is responsible for muscle function. We as dietitians focus on muscle mass. However, early changes in muscle function during malnutrition are also due to electrolytes and reductions in energy-rich compounds. The excellent article in your reading assignment by Christina Norman discusses this further. This diagram, also by Christina Norman, shows several hypotheses for the pathogenesis of impaired muscle function in malnutrition. So starting on the left, you can see reduced nutritional intake results in a compensatory loss of whole body protein, loss from muscle mass. In disease, muscle protein synthesis is also reduced. And as we move to the right, we can see that decreased muscle function is likely related to other factors than simply the loss of muscle mass, which explains also how muscle function can respond earlier to nutritional deprivation and restoration. Changes in muscle function, such as contractility, relaxation rate, and endurance, may precede body composition changes and may show functional impairment at subclinical levels. So you can see there is much going on in the muscle to cause the reduced function related to malnutrition. This diagram is from the Journal of Cachexia, Sarcopenia, and Muscle, and it shows many of the causes of muscle atrophy. You can see the many diseases and how aging and lack of movement all contribute to it as well. So it's very complicated. Now this slide shows alterations in muscle morphology with malnutrition, and it's pretty interesting. So I'll explain it. The type 1 slow twitch muscle is the light staining. The type 2 fast twitch muscle is the dark staining. The picture on the left is normal. The picture on the right is after the restriction. This slide is of muscle biopsies of a morbidly obese patient. A morbidly obese subject here, after 2 weeks of starvation, consistently showed fast twitch muscle fiber atrophy in their gastrocnemius muscle. This was after 2 weeks of a 400-calorie diet. There was a marked rise in the ratio of type 1 and type 2 fibers. The change in ratio was due to the decrease in the number and size of the type 2 muscle fibers. And there's also degeneration of the Z disc in malnutrition. The sarcomere extends from Z disc to Z disc, which move closer together with each muscle contraction. So this is an interesting slide of a small study. It shows declining grip strength in 3 different conditions. The dynamometer assessment not only reflected body mass, but could differentiate between undernourished and merely underweight individuals with equal body mass indexes. So there were 72 healthy males, 34 were normal weight, 38 had low body mass index, and in that low weight group, there was an underweight group of 20 and a chronic energy deficient group of 18. And you can see that with each worsening condition, the grip strength declined and was significantly different from normal, and the chronic energy deficient is different from the underweight. So you see the dominant hand, the normal weight was, the grip strength was 40.1, and then the underweight, it was 38.3, and then the chronically energy deficient was 30. So that was very interesting. So hand grip is an indicator of muscle function. So muscle function is an indicator of the functional and nutritional status. And then we have this dynamometer used to quantitate the assessment of muscle grip strength. The hand grip is the most feasible bedside method. It's a test of maximal force in pounds or kilograms produced by the muscle, and it reflects maximum strength derived from combined contraction of extrinsic and intrinsic hand muscles, and it is sensitive measurement of short-term nutrition status, and it correlates with outcomes from surgery and from clinical improvement. So to orient hand grip for our purposes, you are all familiar with the 2012 consensus from the Academy in Aspen. The consensus set important common groundwork to help bring order, correct historic confusion, interpretive errors, coding errors, and provide a more current nutrition science-based rationale and common language for bedside practitioners. So now we can all start at a reasonable place and identify our patients with a common improved orientation and terminology, something sadly lacking historically for clinical malnutrition. So this diagram will refresh you on where grip strength fits into the bigger picture of the consensus. So we have at the top the screening, and then deciding what type of malnutrition the patient has: an acute illness or injury, disease-related malnutrition, a chronic illness or injury, or social environmental circumstances, or a starvation or semi-starvation type. And then there's the 6 characteristics: reduced energy intake, weight loss, muscle mass loss, body fat loss, fluid accumulation, and then right there, decreased hand grip strength. That's where it fits. And then it goes on to determine if your patient's malnourished or not. So the standard, the reduced hand grip strength was included as a characteristic of malnutrition by the Academy in Aspen because of its use in documenting the effects of loss and decreases in lean mass and muscle mass and function, which can occur before weight loss is observed. However, minimal research has been conducted to establish normal reference values for hand grip strength during acute or chronic disease states. The Academy in Aspen recommend consulting normative standards when determining your patient's hand grip strength is measurably reduced. You can see the term measurably reduced pertains to the 3 types of severe malnutrition, not the moderate or mild forms. We can see a diagram of this relationship on the next slide on the standard bell curve. The standard bell curve shows the mean or average of a measurement at the midpoint of the bell curve. Then you can see minus 1 standard deviation on the left and plus 1 standard deviation on the right. Then see minus 2 standard deviations on your left and plus 2 standard deviations on the right of the bell curve, in the bell curve. Measurements between minus 1 and minus 2 are considered within the normal range in statistics, and it is only the measure beyond minus 2 that is outside that normal range, and what we are now describing as measurably reduced. The other way to describe this is with confidence intervals. You can see that the measure outside the 95.5% confidence interval are outside the normal range. Grip strength works the same way, and you can see that the measure is either within normal range or outside normal range. There is no defined moderate or mild location. However, clinically, you will see people beyond minus 1 and very close to minus 2 SD. This is one reason also why patterns of measurement are important, so one can see the patient's changes and integrate the measurements, the pattern and meaning of the information to contribute to the overall patient nutrition assessment and the nutrition diagnosis if the exam methods are identical. And that's why there's so much emphasis on performing the exam accurately. So a hand grip in healthy people is influenced by age and gender. Most studies and their normalization tables stratify their results based on age and gender. However, in unwell people, in addition to age and gender, all of these many factors shown on the slide are influencers, such as comorbidity load and immobilization and inflammation. So you can see how one could talk yourself or oneself out of doing the hand grip evaluation, since we know these factors are often present. But don't talk yourself out of it. It looks more troublesome on paper than it does in real life. So what about obese patients? Increased body weight is associated with reduced physical activity, reduced mobility, and an overall sedentary lifestyle. Absolute hand grip strength is not significantly different between obese and non-obese. The same normalization tables are used. Muscle function of the lower extremities in fat-free mass can be higher in obese patients because they're carrying more weight. This is a reason that hand grip is used for overall assessment for nutrition purposes. So while obese patients can also be quite strong, there is not a difference within the normal range. So grip strength is equally valuable in all populations, and the same normal charts can be used. So what about contraindications? There certainly are contraindications, but surprisingly fewer than you might think. Let's look at cognitive impairment and dementia. Well, cognitive impairment depends on the severity of the person's impairment. And as long as the person is able to follow instructions and squeeze completely and safely and understand how to do it, then it's probably okay if you need it for clinical information. So it would depend on how far along on their impairment and then how rapid the decline would be for future safe measures that would implicate nutrition. So consider this and decide for that individual. You may or may not deem it okay or clinically useful. So neuromuscular disease and impairment. Probably not, as it is not able to differentiate nutrition-related reasons very well due to the nature of the neuromuscular disease. However, it does not necessarily rule it out, as people may be pretty stable sometimes. Those who measure change in neuromuscular ability may use grip strength, but they use it for different purpose. For example, in amyotrophic lateral sclerosis, which may even need a different type of dynamometer. So what about a CVA and on the affected side? You can perform the exam on the non-affected side depending on the patient's capability on that side and ability to follow instructions, and if the CVA was recent or a long time ago. So you'll have to decide. Rheumatoid arthritis of the hands. This one really surprised me. A couple of years ago, when I was reviewing my slides with our certified occupational therapist, she stopped me when I said that arthritis was contraindicated, and she said that it was not necessarily contraindicated, because the exam does not harm the patient and that they would become their own normal. So arthritis does not necessarily need to be a contraindication. If there's a flare, it may not be the right time for the exam. And if gripping causes any pain for anybody, stop. You will see later that the patient is instructed to stop if gripping hurts. Again, just consider the situation. Now, what about injury or malformation of the hands? It just depends. The patient will become their own normal again. We had a situation one time when I was training some dietitians, and our practice subject said she had long-standing nerve damage to one arm. So we performed the exam, and on that arm, and she was on the low side of the mean, but still within the normal range. Her right arm was above the mean. She was within normal range for both her grips. However, if she had become ill or malnourished, we would still have used subsequent measurements for her rather than comparing to the normalization tables for her age and gender matches on that one impaired arm. Or we could have just performed the exam on the non-affected side, which was an option, and the patient may prefer to not use the nerve damaged arm. So what about ICU? When I was first working on this, grip strength was not indicated for ICU, likely due to all the electrolyte and metabolic changes. However, recently I saw a report where grip strength was performed on an ICU subpopulation. So if your patient is stable enough to have the exam, depending on the situation, you probably could measure it or at least get a baseline measure. Your patient would need to be, stable enough, whatever that means in their situation, and able to hold the dynamometer safely and perform it safely and hold the position. So consider these situations, and it may be fine or not at that point. Now, incorrect technique and uncalibrated equipment are clearly contraindications. Funny story, I was doing this training with our occupational therapists to update them on what the dietitians were going to be doing for purposes of nutrition assessment. And one of the OTs was really worried about herself because she was self-taking grip exam and the reading was repeatedly very low. She was really worried about this and really thought something was wrong with her. And I thought about it and I said, well, why don't you try my dynamometer? And she did. And she was perfectly normal. And it turned out the OTs got to talking together and realized they had not had their dynamometers calibrated in a number of years. So it was really off calibration. So that's a good lesson. So now, limits to grip strength. It's really important to have consistency in measurements. This is where methodology comes in and why we have the gold standard method specified by the American Society of Hand Therapists. Measurements can be affected by many things like posture, time of day, and the handle position of the dynamometer. Grip strength is used primarily, again, as an indicator of upper limb strength. So, and the hand grip exam cannot replace evaluation of activities of daily living, the strength of the lower limbs, or walking speed in fragile populations or in patients with neuromuscular disease. I always get questions about the right hand or the left hand, and as I understand the statistics and study challenges, they would need to collect so much data to create the normalization tables for left-handed people that it is just not practical. And if you think about it, a person could be left-hand dominant and still stronger on their right hand, or think about a right-handed mom who carries a kid around on her hip, and she's very strong on her left side. So the normal tables are for right hand and left for age and sex. One cannot assume a left-handed person is stronger in their left hand. Something I found that I first thought was an error is on the male normalization table that came with the JMAR that's in the toolkit. The grip strength goes up at the 65-year-old category, and after having gone down for most of the prior history. The only reason I can think of is that 65 is about when men tend to retire and must maybe have a spurt of physical activity that shows up as an increased grip for a little bit. This is just a guess, but it is not a transcription error on that blue toolkit chart. The first time the patient experiences the exam, they are naive to the exam, so it's important to orient the patient to the equipment and let the patient hold the dynamometer and squeeze it a little bit to see that the handle just does not move. That way, they will be more familiar and not tentative for the first exam and give their strongest grip. One of the NIH videos on the reading list shows the NIH examiner letting the patient hold and get familiar with the equipment. There is specific phrasing for the examiner to instruct the patient so that the patient is not performing for the examiner. You can find the phrasing of the pattern instructions in the toolkit in the DPG newsletter article reprint. One of the things that the OTs are careful about, and something the grip methodology is called rapid exchange. It's structured to avoid this concern, and it's called patient malingering, or pretending to be in worse condition than they are. The OTs are very aware of malingering because disability or insurance may depend on the patient's grip strength results. Their patients may want to falsify the test. And this is hard to imagine occurring in our nutrition world, but it is good to be aware of this potential. The methodology described by the ASHT is used to help avoid these problems and help overcome these potential limitations. I would be surprised if patients did this regarding malnutrition, but one never knows. It is a good idea to be aware of it as a dietitian. The method we will learn is called rapid exchange, and part of the reason for this is to avoid faking the grips. It's how the brain functions with the rapid change. It's hard for people to make up what they're doing. Also, the rapid exchange fatigues muscles if the patient is malnourished. And there will tend to be a stronger first grip, and thereafter the grip strength kind of drops off to the weaker muscles and the initial creatine phosphate being burned up for fuel with that first squeeze. And this is important for nutrition information. So some key things to remember is that hand grip strength for the purpose of diagnosis of nutrition factors such as malnutrition should be used in conjunction with other nutrition assessment data and clinical judgment as part of the nutritional assessment by a registered dietitian. There is, again, still no magic single test to assess malnutrition, and results tend to be helpful when repeated over time. And of course, further research is needed, and changes may be made as practice changes and as progress is made just in general with nutrition. So now we're going to go over how to use the dynamometer. This is very important for consistent methodology and the meaningful results. Again, this method is considered the gold standard by the American Society of Hand Therapists and the American Society of Surgery of the Hand. And this method is the most widely used and recommended, and there seems to be most research based on this method. So this is a picture of the JMAR digital dynamometer on the left and the dial dynamometer on the right. You can see the position of the patient's hand holding the dynamometer, grasped comfortably with the first finger nestled toward the top of the curve of the grip. Because the patient is holding the dynamometer, the face of the dynamometer is positioned facing the examiner so the examiner can read the results. You can see the strap over the arm of the patient. The strap is to keep the patient from harm if they drop the dynamometer. We have not had to use this strap, but certainly could. Most patients seem able to grasp without using the strap. I'll show you later how the examiner can position their hand underneath the dynamometer to make sure it's safe for the patient. Now, I've encouraged people to buy the digital dynamometer over the dial version. It is a little more expensive, but I've done that because you get the reading immediately on the digital readout to the 10th decimal place. The dial dynamometer, you have to pause and look at the dial and study it a bit to find the little teeny markings to determine the measure, and it does not read to the 10th decimal. And I've not found need for the dynamometer version that comes with an app, but I can see there may be some settings where that app could be useful. So we just get the digital one on the left. So results are read after each grip between each hand exchange. The digital readout reads out right on the screen to the first decimal point, and you do not have to study the numbers like you do in the dial. I find this more useful and easier to manage during the conducting the exam. So there are quite a number of things to prepare when you're going to launch this training program and the examination. One thing I'd like to remind everybody is that it is not completion of this program that makes you competent. Your supervisor decides your competency and what you would do at your work. You do want to be sure and use an approved hand grip dynamometer. Again, I think the digital is easier because of this 10th decimal point reading. And the manual version has the dial readout, which I find more difficult to read quickly and precisely, but both will work just fine. It is recommended to use the normalization tables that come with your dynamometer. So in this case, with JMAR, and that is what I've included in the toolkit also. So you will need to get facility engineering department to approve and sign off on your equipment. This is standard facility procedures for equipment. The instructions in the manual that come with the dynamometer say to have it calibrated annually. And I would suggest talking to your biomedical engineers, though. I asked ours about this, and they calibrate much more complex equipment than dynamometers. They told me that the equipment probably does not need to be calibrated annually and that they could do it in-house. And I like that idea because I was concerned about mailing equipment away, so that alleviated some of my concerns for a yearly calibration. However, check your warranty also. I believe the equipment is really stable, though. For example, our first dynamometers, I had not had them checked for a couple, 3 years, and the engineers said they were exact. So that's good to know. Have some cleaning wipes in the dynamometer case, and that way you can demonstrate using them to clean the equipment before and after using it on the patient. And you certainly may use gloves if you like. You'll want to have paper and a writing instrument with you or have it at hand, and a calculator is useful once you have obtained the readings. You will want to have any facility approved forms. Now, I've provided a sample worksheet for you to record the examination results during the exam. Using the worksheet is a great way to start out, as it will walk you through the process and you can preload or write in the normal measures and the alert levels before you even perform the exam. Now, after a while, you may graduate to what I call the paper towel method, which is me forgetting to get the worksheet, grabbing a paper towel in the patient's room, drawing a line down the middle, and writing an L on the left and an R on the right for the various grips. Now, again, on the left, we see how the patient is to hold the dynamometer. Look at the picture on the right. What is wrong with this picture? This is a very common mistake, and someone in every class seems to do it once and get a good laugh. This is the wrong way to hold it. Now, because we naturally want to look at the face of the dynamometer, sometimes people grasp it backwards. The face of the dynamometer should be toward the examiner, and the patient does not see the face or the readout. Now, if you have a scribe when you're doing your examination, a third person, you can read the result to your scribe. Just say the measure, and you do not need to say in pounds or kilos, and your patient does not need to know any interpretation. Now, a reminder that consistency with following the exact methodology is crucial. Many things such as posture, arm side, or handle position can alter grip strength. That is why there is a preferred protocol, which is from the American Society of Hand Therapists, and is the methodology we are working on today. This methodology is used because it was found that grip strength is highest when subjects were seated in a chair with their elbows not supported by chair arms. In this position, there is optimal overlap between the actin and the myosin filaments. Grip strength becomes stronger due to the synergistic action of these other muscles. Now I'll describe the ASHT method. So seat the patient at the standard position, which is seated upright in an armchair with their arms unsupported, shoulders relaxed, elbow at right angle, and the wrist not bent, or seated at the side of the bed in that same position, or in bed with legs straight out at 90 degrees. You take 3 measurements with each hand alternating. Each grip is about 3 seconds, and there is about 15 seconds between the trials. Test and record the value 3 times each, alternating hands in a rapid exchange. Then sum the 3 values on each side and divide by 3 to get the mean, or the average, for each hand, and record the measurement for each hand. The photo on the left shows correct arm position of the patient. The patient is sitting up 90 degrees and the arms are held at the side. The grip on the handle is set to number 2 position, so the hand fits comfortably toward the top of the grip with the fingers wrapped. You can see the elbows are not resting on anything. The photo on the right shows the elbows resting on the chair. The ASHT again recommends not resting the elbow. I have read methodologies, though, that do include resting it, but for our ASHT method, do not. And there's the grip position number 2. So this photo shows the examiner on your right and the patient sitting in the correct seated position on your left. The elbows are bent at 90 degrees angle and the patient is sitting straight up. The face of the dynamometer is positioned so the examiner can read it. This is another view of the examiner at the bottom of the picture. The examiner is giving the dynamometer to the patient with the examiner's left hand gently positioned underneath the dynamometer so that it doesn't fall on the patient. But what about that lower arm position of the patient? And is the patient sitting up and straight up? No. Neither the arms nor seated patient position is correct. The arms are not straight out, but the hands have moved midline, unlike the previous picture. And the patient is not sitting straight up, but slightly slouching. It is very important to make sure your patient is in the correct position and remains in the correct position. Instruct them to do so at the beginning and during the exam so they do not alter their position. Here's another photo of an incorrect arm position on the left and the correct arm position on the right. The movement pushing the arm forward as shown in the left picture is also a very common mistake. So be alert to this mistake when performing the exam, or if you are spotting the exam, watch for this pushing forward error as people squeeze. And also watch for the hand moving to midline and the elbows pushing out. All that is incorrect and do not allow the ability for the strongest grip. I've noticed that some people kind of throw their shoulder up and forward and grit their teeth. Do not let this occur, as it is not the right position, and the shoulder muscles then are involved in interfering with the results. I've noticed especially with men where they throw their shoulder into the grip. The shoulder must be down and relaxed. We are measuring the lower arm and hand. When the patient sits straight up with the elbow bent, it isolates those lower arm muscles and the upper arm somewhat. So do not let that shoulder shift forward or throw it forward. That is the wrong position. I mentioned the position of the handle. This photo shows the inside bar is position 1. The left notch toward the position forward from this position is position 2, and the one beyond that is position 3, and then 4, and it goes on up to position 5. Position 1, 3, 4, and 5 are generally not used unless there is a really small or really large hand. We have had very petite people, 5 foot tall or less, and also very large people tested, and they were at position 2. So the inside handle that I'm talking about comes off. And you can see that in the picture on the left. That's how it's moved to position 1, 2, or 3. Swing the bottom part out and the top part will drop out. Then move the curved handle piece to position 2, the second notch from the handle on the bottom, and match it to the notch on the top. The arrow points that there is a, note on the photo on the right that there's a little black arrow on the inside of the removable handle. That arrow points up. Make sure the handle is positioned so that the arrow points up. Otherwise, the grip will be upside down and not right. Also, be careful not to turn this handle out so that it's shaped like an O. So I'll let you look at that for a second. Now, what to avoid, the picture on the left has this handle set too far away for this small hand. And you can see the fingers are not grasping properly. The grip on the right is opposite and set too close for a very large hand, and it's also very rare. We have not yet had to move a hand position to 1 or 3, and our OT has told us to just keep the dynamometer set to position 2. But that's how you can tell if it's too big or too little, if the hand is not grasping it, like in the other example pictures that were accurate. Now here's another view. You see the first notch, number 1, and that's again where you would rear. And then you see notch number 2, position number 2. And at the very bottom of that handle, there's a little hex screw. Be gentle with that screw, but once you have the handle in position, it can be held there with that screw. Just don't over tighten that little screw. You can see here at position 1, 2, 3, and we've got that handle set correctly at 2. So here's a better picture of that little screw, and it's a very small hex head driver and does not come with the dynamometer. Then your engineers can get you one if you need it. So if the dynamometer comes already set to position 2, you really do not need to change the handle position. Some of the dynamometers have come set in position 1. in the case, and the case used to come with the cushion allowance for position 2. It used to come that way, but now it was changed so that the cushion forces it to position 1, so it's more difficult. So when you use it, you have to alter the handle. I prefer just to keep the handle at position 2. So when you order your equipment, you may want to see if they can have the case fit so that you can hold the handle in position 2. Otherwise, you have to move it back and forth, although I've thought maybe I would just cut it out myself. So it's just awkward because you don't want to move that handle around and use that little screw very much. So if you tighten to that screw, just don't over tighten it. So now we're going to learn how to use the control panel on the dynamometer. In your toolkit, it's on page 30 and page 29. And we have a sample large size simulated face of the dynamometer for you to look at and practice with, just to get the idea of the buttons. So you may want to go to that paper right now. It's on page 30. And there's also a small version on 29 where that's the pattern of the whole simulated dynamometer. So it's very easy to figure out the buttons, but it was a little scary for me at first. So I thought the sample face would help everybody on our program here. So first, the central button. This is the on-off button. To turn it off, you have to press and hold for a little bit. So first look at the upper left button, and it says select test, which tells which hand to start with. That is, it will let you select L for left hand or R for right hand or both. And we're going to set ours to LR for the left-right hand. So you push that button until you see LR. Next, look at the upper right button. Whoops. And the upper right button says number of trials. And that's the number of squeezes on each hand. So we will squeeze 3 times on each hand. So we could set the trial at 3. So push that button until it's set 3. But I want you to instead to set the trials at 4. And I'll tell you why in a bit. The upper left button tells which hand to start with. That is L for left hand. So we will set ours again to LR for left right hand. We have just set for LR4 at this point. The lower left button is important. This button is labeled test. Before each squeeze, you must push test so the dynamometer can measure each individual grip or squeeze. When your test doesn't work, you will learn pretty fast that you forgot to press the test button between each squeeze. The lower right button is the reset button. You will reset between patients, or if there is a mix-up and you need to start over. You can also just turn the dynamometer off and on to reset it for the next patient. The rectangular readout panel on the left there is where the results show for the digital dynamometer. At the top of the panel, LR shows and the number of trials you have selected shows. So this is kind of blurry, but it shows the LR4, meaning left, right, and 4 squeezes each hand. So the left, right sequence is right there, and that's the number 4 of tests for each hand. And again, we only need 3 each, but if there's a missed test, there is 1 extra test available, and you can do it, and you don't have to redo the whole exam. So that's why I have you set it to 4. Now you also want to have it predetermined in pounds or kilograms, and I've supplied the charts in pounds and kilograms. You just have to make sure you use the right setting on your dynamometer and the right chart to make sure you get them all right. Yeah, okay. So now let's go through the sequence. So you turn it on first right there, and then you select test, which is over there, and you make sure it says LR4. Now you only need to set test once with the new machine, because the dynamometer will remember that every time you just turn it on thereafter, but you want to always check it. And then you also need to make sure to push the number of trials button so it says 4. And then you have to select test between each exchange of the hand to allow the machine to give you the correct readout. And then the resets to LR4 when you go to your next patient. So once you start testing, the upper corner will show you where you are in the test sequence, left hand or right hand, but it does not matter actually, because you are not going to have the dynamometer compute your mean. We're going to write it out ourselves. So we're not going to auto-calculate it. So it really doesn't matter which hand you start on, but you have to have the dynamometer set to that LR4. So now here's a photo of the sticker that the biomedical engineer puts onto your equipment when it's checked out and approved for use by them. And this is how you set for pounds or kilograms. Also, if you pull the back off the top, let's see if that's the next slide. Yeah. If you pull the back off the top piece of the dynamometer, you can see that there's this little switch inside there. Flipped one way, the dynamometer will measure in pounds, and flipped the other way, it's in kilograms. The dynamometer comes preset to pounds. And that's where that is. Okay. Now, remember that I had you set the dynamometer to LR4 instead of LR3. Now I'll go into why I think you want to do that. So the digital dynamometer will automatically calculate the mean of the 3 readings of each hand. So if you let it auto-calculate, you must start with a squeeze on that left side first, as the dynamometer shows it. That is what the LR means, left and right. But I do not recommend that you let the dynamometer auto-calculate, especially now when you're learning. I want everyone to write each result and do your own math. So if you're doing your own math, even though the dynamometer is set to LR, it just does not matter which hand you start on, because you are going to manually calculate the mean. Just make sure you are doing it for each patient left hand and their right hand, and do not mix up those columns, because the machine just measures and doesn't care which hand it is when you're doing your own math and your own calculation. Now, why would I have you set the trials to 4, since we're only doing 3 grips on each hand? This was recommended by our OT who trained us, and it is to allow you to keep moving the test along if there's a fumble by the patient or the examiner. The digital dynamometer is very sensitive to the grasp, even a very light grasp. So if on the 3rd squeeze there is a fumble, or you or the patient squeezed the dynamometer just a little bit before the exam, the machine will have measured that light squeeze and frozen it and accepted it as a true reading, but it was a mistake. So having 4 chances allows you to hit the test button again and then continue with the exam without slowing down. Remember, you're doing a rapid exchange, squeezing, writing the result, switching hands, squeezing, writing the result, switching hands, squeezing, writing the results, and switching hands for a total of 6 times, alternating 3 grips on each hand. So let's do a review. You turn the power on. You confirm your LR and 4 settings on your hand and figure out which hand you're going to start first on. And it doesn't matter since you're auto-calculating, or since you're manually calculating. And make sure your readout is in pounds or kilograms, your preference. And then confirm the dynamometer equipment grip position. Make sure your patient's got it in the right position, and that would be the second one. And then position your patient. Make sure your patient is seated in a chair facing you with their arms free and their elbow at 90 degrees, or on the side of the bed or in the bed. And we have done it in the bed, and you just raise the head of the bed up and have the person stick their legs, out as straight as they can and keep their arms free, and it works just fine. And then place your pre-filled out recording form and writing instrument at hand, or have your scribe there with you. And that works really well to have a buddy, especially when you're starting. It's fun and it's very helpful. So then what I have you do is pre-fill out your worksheet. And I'll show you, the worksheet is on page 23. And so you put the name and the date and the age and the sex. Make sure it's in pounds or kilos, and then find on a chart. I'll show you how to do that in a moment. The normal mean for that age and sex, and the alert score for that age and sex. You would greet your patient, confirm permission, and explain you're going to measure how strong they are in order to help assess their nutrition status. Help your patient to relax. Make sure others are in the room are appropriate for privacy. And I discuss a little bit more about that in the DPG newsletter article. Make sure the patient sees you wash your hands or put your gloves on if you're desired. You can wipe down the dynamometer to make sure your patient sees that, and then confirm your settings. Make sure your patient's positioned right, and then press on off to start the instrument. Confirm your grip handle is in the best hand size with the patient, and then have the patient grasp the device gently to get familiar with it and get comfortable with it. And you don't want to have the patient squeeze it really hard because it would kind of use their muscle up, but you should have them handle it a little bit, maybe squeeze a little because it doesn't move, and everybody thinks it should move, but it doesn't. So, and then make sure it's facing the right direction, that the readout is facing you. So you press test to begin the first test trial and instruct the patient to squeeze the grip, and you let them squeeze it for about 3 seconds. You want them to get to their maximum grip strength. And there's also some special language for this instruction I'll show you in a bit. And then you take the dynamometer and have them switch hands, or they can switch hands themselves. Just make sure that goes, and try to keep it, don't count the 15 seconds, but try to keep it pretty rapid so that they fatigue the muscle and they get a true reading. And then record the result of each grasp under the correct side hand on the form. And so then you complete the first test, you push test and you get the reading, and then you do the opposite hand and you hit test again. So that will reset the dynamometer so it can measure that next hand. And you repeat 2 more tests on each side, opposite of one another, again with about 15 seconds between. Record the result of each test on each hand between tests, and then you're done. Press on off. It takes a little bit, and that will turn your machine off. And you be sure to thank your patient and generically report results to the patient as appropriate. One thing I found useful is just an emphasis on nutrition and diet to help with gaining your strength, and kind of an orientation to patient ed to reinforce some of our nutrition messages. And just make sure it's the appropriate context for telling the patient the results. So turn it off, clean the equipment, and put it safely away. Now here is and this is also in the DPG article, these are suggested standardized instructions by the ASHT. I have kind of a funny story to tell before I read you this. Many of you probably have been around pulmonary function labs or respiratory departments, and one of our offices is over by a respiratory department. When I first moved there quite a few years ago, I heard these respiratory therapists and they were yelling at their patients. And I was just shocked, like, why are they yelling at the patients? And I eventually found out that that's how you get them to perform for their pulmonary function tests and their breathing tests. Well, a couple years ago, we had a patient upstairs and that in the hospital that needed this, and she was non-English speaking, and her family was not around, and there was a lot of mix-up with the case. But we eventually got to do this lady. We tried to translate her, and that didn't work. So then later I came back and her family was there, and that was much work and wasn't as much, that worked great. And she sat on the side of the bed, and so I did the exam, and after each exam, during the instructions, I told her really that I just threw, because it'd been quite a production to get her to this point. And I said, I was kind of yelling a little bit, like squeeze, 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 and just really pushing her. And after I finished, I thought, gee, I wonder if I was supposed to do that. So I went back and looked, and you're not supposed to do that, because that causes the patient was performing for me, and I needed true reading. So you're supposed to give kind of a firm instruction to squeeze and make sure that patient squeezes as hard as they can, but you don't want to over push them or under push them. So you don't want to make it real casual so that they don't give you a full squeeze, but you don't want to be yelling at them so that they'll really, really give so much of a squeeze that it's for you. So this instructions by the ASHT, because they have many, many years of experience with this is what they say to say. And so I don't know that you have to say it exactly, but I would say it pretty close. So this would be what you would tell your patient. This test will tell me your maximum grip strength. When I say go, grip as hard as you can until I say stop. Before each trial, I will ask you, are you ready? And then tell you to go. Now stop immediately if you experience any unusual pain or discomfort at any point during the test. Do you have any questions? Are you ready? Go. Then as the client begins to squeeze, the examiner should say harder, harder, and then relax. But you just don't have to yell it, and you don't have to overdo it, but do it enough so that you're giving a command so that the patient will perform. So, and then be sure to tell the client to relax when the dial of the dynamometer levels off, or in the digital one it freezes, and then and that'll happen usually about 3 to 5 seconds, and then you've got that reading. So now I wanted to show you in the toolkit there is a couple of videos, and one of them is from the National Institute of Health, and it's kind of tricky to find it. So I've got the link here, and what you do is it'll take you to a area that looks like this, and it'll say number 52 grip strength. And then click on that, and it pulls up and shows an examiner and a patient. And they're doing the right methodology, of course. That's the NIH. But in that one, she showed the patient the result of the reading, which we don't need to do or don't do on this. But that positioning of the patient in the instructions is correct. So you can use that. And then the other YouTube video here is they're not writing down the result, but the rapid exchange is shown really well about how that's done. And they're a rehab PT person doing it on an injured arm on a student. But that flow will show you them kind of a good pattern of the movement of the speed of this. So those are two good videos, and it's in your toolkit. So now this is the picture of the client on the left in the correct position and the examiner on the right. And what I've done here is, this is the JMAR, and the ASHT method. So I have a little excerpt of the normative grip strength chart that I made from the data in the book that came along with the JMAR. So the first column, and this starts at age 6 and it goes to age 75, and it's in your toolkit. There's a series of blue ones and pink ones for men and women, and they're also in pounds and kilos. So the first column is the age range. The second column is R for right hand and L for left hand. The third column is the mean, or the average, for that age group of persons for the sex. This is a female chart that we're looking at. And then there's one standard deviation. So that's what you get in the chart that comes with your book. So what I took the liberty to do was create a column of 2 standard deviations, which is double 1, and then you subtract 2 standard deviations from the mean. So in this case, for the 20 to 24-year-old, I have the mean was 70.4, and the 2 standard deviations was 29. So I subtracted 29 from 74.4 and got 41.4. So that's what I'm calling the alert level. So your patient at or below that alert level would be the one that's the -2 SD below the mean. So that's how I did that. And I did that so that you can just look at a chart to pre-fill out your form and you don't have to do the math. So again, you have your patient mean of 3 measurements. And there's, again, a right hand and a different mean for the left hand. 2 SDs below the mean is subtracted from the mean, and then that will give you the values. So that's an example of that. And again, this is what we're looking at. This is the -2 SDs below the mean, and that's what we're calling measurably reduced. Now this is that sheet that I took the liberty to take from the JMAR book, and the age column, the hand, the mean, and 1 SD was in the book. I did the 2 SDs and the alert level. So I just did that for ease, and I have checked these numbers multiple times. You probably should there, and also the reference for them is in the toolkit that these were from the author who did all this. And this is the female sheet, the age, hand again. So here's a 30 to 34-year-old person. Right hand mean was 78.7, 2 SDs is 38.4. I subtracted 38.4 from 78.7 and got my alert level of 40.3, which is minus 2 SD from the mean. So now one thing that I have, and I think I said it was on page 23, is the worksheet. So I'll show you how that works. And I end up using the paper towel method because I seem to run out of my worksheets, but this is something I think will help when you're learning to get it all right, and I think it will be easier too. So you sum the 3 scores on the right hand and divide by 3 to the aid to obtain the average of the mean for the right hand, and you record that mean in the appropriate box on the form. And then you do the same on the left. You locate the alert fill. So this is, you locate the alert level on the form, on that blue or pink form, and then so you know that. And then what you're doing is you're comparing your patient scores to that score of the alert level. And you're saying, is the patient within normal for age or sex, or is the patient outside the normal for age and sex? So, and if the patient can only be tested on one side, you just do that. But the weaker the grip, the closer to minus 2 SD below the mean the patient will be. Now, this is a picture of the worksheet. And so I'll show you again. Sorry, this is redundant, but I want to be helpful. So there's the pounds. So you circle if it's pounds or kilograms. And again, the dynamometer defaults to pounds. You put your patient age, your patient sex. You put the normal mean from that pink or blue chart for the right hand and for the left hand. And then you put the alert level from your chart for the right hand and the left hand on that form. So that's all pre-filled out before you go in to see your patient. And then all you have to get is the 3 readings from the right hand in the mean and the 3 readings from the left hand on the mean. And then you look at the results of the patient's right hand and left hand mean, compare it to the normal and compare it to the alert level, and then ask your question, gee, is my patient within the norm or is my patient below the alert level? And those answers will be opposite one another. So here's what it looks like partially filled out before I go into my patient, just like that. And then there are other reference ranges available in the literature, and there probably is more research needed to develop the reference ranges for target populations. So you do need to use your clinical judgment, but one of the most important points is that you're getting baseline and trending information over time for your patient. So comparison to the normalization tables is for, a large population, and you may be dealing with a subpopulation for which there is or is not normalization tables on, but the patient can become their own normal too. And so this works nicely if you have the liberty of seeing patients over time, but it can also just work, compare it to the normal table. That's a well done normal table and it works with that dynamometer. So that's what you would do. Now you have to start documenting results. And if you think about how a lab result is documented, in a lab result, they'll give you the measure, what it was, the units of measure, what the normal range was, and it'll flag it if it's outside the range. So this recording of results is what that is a replacement for. You also separately have an analysis of the results. So those are 2 different things, and we'll go over that a little bit, and I have some samples for you. So this would be your potential results chart node. So you would have your right hand and your left hand, and you would have each of the 3 readings, and then you'd put your patient mean or the patient average in it, and you would also put in what was the normal for the age or sex. And then you'd have a statement about, you'd have a statement about the right hand and the left hand mean are within normal plus or minus 2 SDs from the mean, and that's normal for their range for age and sex. And then you would describe the patient position, that the patient agreed to the exam and that they tolerated the exam and who was in with the exam. And we had, originally we weren't doing that, and we had some experiences with some other things, and I thought, it's a very good idea to state that the patient was agreeable to this exam and that they tolerated the exam. Even though this is such a low risk exam, I think that's a very wise thing to put in a chart, and also if any appropriate person was present to state who was present, and then you would sign that note. So that's an example of kind of a normal. Now this one would be, you'd have the same information and you'd state the 3 readings, and then you'd have your patient, state your patient mean, and then what the norm was. And then you'd have it, the right hand and the left hand mean are more than or beyond -2 standard deviations from the mean and measurably reduced from normal for age and sex. So you're just stating this very dry facts about your results. And here's one that's the same thing, where the patient isn't quite at 2, and you put the results in for each hand, the mean compared to the norm. Right and left hand mean are more than -1 SD, but less than -2 SD beyond the mean, therefore within normal range for age and sex. And I believe you could say that they were towards the lower end of normal for their age and sex. And again, what the position was in agreement. So that's kind of the example of that. Now you also, again, have to do the clinical analysis. So these were some pretend ways to do that. You could say the patient hand grip strength test results. Patient mean score is measurably reduced and more than -2 SD below the mean for age and sex, indicating reduction in a measure of functional status likely related to poor nutritional status. You could say a patient hand grip strength test results. Patient mean score is within normal range for age and sex. Or you could say, in conjunction with the patient 20-pound weight loss, 7% since May, reduced intakes of calories and protein to 60% of usual for the last 3 months. And you could say the average estimate, 1,200 calories and 50 grams protein per day. Hand grip strength indicates measurably reduced grip strength, as is more than -2 SD below the mean for age and sex. Data supports nutrition diagnosis of chronic severe protein calorie malnutrition. You could say that the reading is measurably reduced. So those are some samples. So now, does grip strength improve with feeding? And there's a couple articles here. The results supported were on this one by Windsor. The results support more widespread use of grip strength measurement in the identification of patients at a high risk for post-op complications and the monitoring of patient response to nutritional intervention. And there's another one, and this one is from an eating disorder group. Within 4 weeks of oral refeeding, maximal relaxation rate and muscle fatigability were restored to normal, and within 8 weeks, all parameters of muscle function were normal. Normalization of muscle function may be related to restoration of muscle electrolytes rather than repletion of body nitrogen. So there is reactions to this, and that was one of the strengths of it, that it'll measure decline and restoration. Now, I'm just going to spend a moment on sarcopenia, or age-related wasting. There's some very interesting literature on this, and it's referenced here, but it is such a big problem in society, and they actually were 2 groups. This one is from Europe, and they were talking about malnutrition and frailty, and they came up with some standards in a group, and it's called the European Working Group, and they're looking at hand grip strength is one of the 3 measures that they're looking at. You have to have 2 of these in their structure, and they had a consensus is how they came up with this. So they are using grip strength for that in the European group, and in the, let's see if I have the numbers here. So this was the cut points they came up with for sarcopenia, and it was, and they use kilograms, so the numbers are a little different here, but they also broke it down by BMI ranges. And so you have men at different BMIs on the left in kilograms, and then the hand grip readings, that those were anything less than those numbers would be indicating muscle wasting. And for women, you can see the different BMIs, and also a measurement less than those readings would indicate sarcopenia from the European Working Group. And there was a group, the Foundation for the National Institute of Health Biomarkers Consortium Sarcopenia Project, and they actually were looking at this too, but they used some actual data in their interpretation of this. And they also, one of the things that I think prompted this was that the ICD code 10M62.84, as of October 1st, that is a codable diagnosis of sarcopenia, and grip strength is one of the measures. Now, it's interesting here because they have just one figure for men and one for women, but they also have an equation to adjust it for body mass index. and I thought that was pretty interesting. And but anyway, there's that one for this FNIH group, and they used actual data in figuring out their cut points for diagnosis. So anyway, those were two interesting points, and I think there's a lot of opportunity with hand grip, and I really hope you enjoy doing this. I want to remind a few things at the end though, but remember, it's for the purpose of use of diagnosis of nutrition factors such as malnutrition. It needs to be used along with our regular nutritional assessment and a good dose of clinical judgment. And then again, it's not a perfect test. It by itself, it's not going to necessarily tell you anything. I don't know that you'll find that many people that are -2, but you'll be able to get trending from individual patients. And so repeating tests over time is useful. And then further research is needed and changes may be made to practice as progress is made. And as I stated in the toolkit, I would recommend keeping an eye on Aspen and the Academy. And if they choose to do other things, I would definitely go with that. I wanted to take a moment to show you your toolkit. And there is the templates for reporting results. There on page 27, there's a spotter checklist on page 28. The simulation sheet is on page 31. So if you do not have a real dynamometer, there is a pattern in there that's the same height and pretty close width of a pretend dynamometer. So you can practice the calculations and practice the positioning with this simulated dynamometer and those simulated results. And you can also practice writing the results and analyzing the results. And then on page 34, there's the competency sheet. You can certainly have, your managers may want you to have a different competency sheet, but that will get you started. And I'm just really hopeful that these tools will help everybody form small groups, maybe get somebody to organize everything, and you schedule every couple of weeks that some reading's done and some work's done. It's a lot of fun, and you can go back through this webinar and look at it anytime. So I thank you very much for your time, and I hope you enjoy this. Be sure to do the reading, and just stay tuned, because I think this is a very exciting topic, and I'm very excited for maybe students can do projects for their special populations, or a dietitian that works in a special clinic can start doing some of this, and that maybe we'll get some more literature on it in special circumstances. So there's a lot of potential. So thank you so much. Bye-bye.